Good afternoon, everybody. It's good to be here. Thank you, Seth. Thank you, Emily. Thank you, Perry. Can you all hear me up there in the back? Your audio's okay? Okay, good. So my task for the afternoon is to talk a little bit about the rationale for applying DBT to adolescents. I'm going to give you a little bit of an update on the research. I'm going to talk about the biosocial theory briefly. I think it's been covered pretty well today, so I'm going to power through that, go over a little bit of our DBT assumptions, targets, and modes. I'm going to show you a video clip of me introducing DBT to a 16-year-old young man. I want to spend a few minutes highlighting some of the skills that Jill Rathis and I added to our recently published skills manual for teens and families, and talk a little bit about the adaptations of DBT for schools and medical settings, and then conclude with some future directions. So I know when I see that year 1995, I definitely am starting to feel older. My eyeglasses, I'm going to start to need a second pair for the reading and the distance. I'm just about at that point. But 20 years ago, Jill Rathis and I started adapting DBT for suicidal, multi-problem adolescents. And we used Marshall Linehan's inclusion criteria, which were targeting adolescents who were suicidal, engaging in non-suicidal self-injury, having multiple problems, multiple diagnoses, and where we started at Montefiore Medical Center in the Bronx, the teens that we were seeing had about 2.5, at the time, Axis I disorders coupled with either borderline personality features or the full disorder itself. And there's been a good number of trials that have been done over these 20 years that have been kind of quasi-experimental studies and open trials. We finally published our first randomized controlled trial last year, which I will show you momentarily, which I'm very pleased about. But since over that time, there's been a lot of adaptations of DBT for other populations that are non-borderline spectrum, non-suicidal, including bipolar adolescents, disordered eating adolescents, and also obviously adapted for different populations and settings like inpatient, residential, like 3 East and McLean, and various other treatment settings. The thought about it, though, and we wrote a chapter on this a couple of years ago, is that the common denominator among these populations is that they have trouble, as far as we conceptualize it, as regulating emotions and regulating behaviors. So transdiagnostically, we think DBT has applicability to a variety of populations. It doesn't have to be exclusively BPD or bipolar or any other specific disorder. And what I like about it is the flexibility within disorders to target using the principles and the targets that I'm going to go over. Now, Carla is very modest, but she published a book, an edited book rather, that I think is a definitive handbook that everybody who works with children and adolescents with BPD should own, should have in your personal library and your office, of course. It's the Handbook of BPD in Children and Adolescents, and it really addresses a lot of neurobiological issues, but it also talks about the existence of BPD in this age group. And a long time ago, people would scoff at me and my colleagues saying there's no such thing as BPD before your 18th birthday. And I think I'm preaching to the choir here. Clearly, those of us who have worked with younger people under the age of 18 who have suffered before the age of 18 know that BPD does exist before your 18th birthday, and this book has data to support that. Now, from a DBT perspective, how do we conceptualize borderline personality disorder? You've heard from Francesca, you've heard from many others. We think about it as a pervasive disorder of the emotion regulation system, and as you all know, the 9 criteria, I'm not going to spend a lot of time going over these criteria, but it is useful that the central problem, as far as we're concerned, is emotional dysregulation, the central problem for BPD, and from that, the sequelae into these other areas of dysregulation are significant, into the interpersonal realm, into the behavioral realm, into the sense of self realm, and of course, in the cognitive realm. So these 5 areas of dysregulation, as many of you know, we relabeled in layman's terms to have these 5 primary problem areas that we talk about, and we introduce teens and families to DBT. We talk about, well, Marshall Linehan's original conceptualization of confusion about self with adults with BPD. We've broadened the term to include reduced awareness and reduced focus. Many of the kids that we work with often talk about kind of being blindsided. Things just come along. They have no idea what happened. They just got upset. Before they knew it, their hands punching the wall. They're cursing and screaming and slamming doors. And they just didn't have the awareness of the nascent stages of the emotion or the action urge that led to that problematic behavior. The part of it is increasing awareness of emotions, thoughts, action urges, and actions. The other part of it, of course, is mental focus. Many of our clients have a lot of trouble staying in this present moment. They're getting mentally and emotionally hijacked from things that have been problematic in their past, and they're kind of sitting in class looking at their math teacher, but their mind is clearly not on algebra. They are often going backwards into some painful things that have happened in the past, or lo and behold, they're drifting forwards mentally and thinking about their ACTs and SATs and, oh my God, I can't believe it, I'm going to fail, I'm going to do terribly, blah, 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 blah. So we want to spend some time with these kids, whether they have ADHD, depression, anxiety, getting their mental camera lens back to this present moment as it is. And when it drifts, and it will, as it does for all of us, and probably for many of you right now at about 3 o'clock on a Friday afternoon, you will notice the drift, hopefully, and say, what is Alex saying again? Yes, what is Alex saying again? So, yes, you will try to practice mindfulness during this next hour. That would be very good. So, we teach mindfulness skills, and many of you in the audience are familiar with, which is teaching our kids and their parents how to observe and describe non-judgmentally what their experience is in this moment with compassion. So that is critical, a core skill that underlies the entire treatment. And as many of you know who do DBT, we're going to repeat mindfulness throughout the curriculum. So mindfulness, then we'll teach distress tolerance to deal with impulsivity. Then we'll go back to mindfulness and teach emotion regulation skills to deal with emotional dysregulation. Then we'll go back to mindfulness and teach interpersonal effectiveness to deal with the interpersonal problems. Now, after a bunch of years of doing this standard DBT package that Marshall Linehan developed, Jill and I realized that there were a lot of teenager and family dilemmas that were not sufficiently being addressed in the standard DBT package. So we adapted some and developed some new skills called walking the middle path skills to address some of what many of you in the audience probably know is intense polarized states between teen and a parent, between one parent and the other parent about how to manage this particular adolescent, between therapists and teenagers, between therapists and the parents of those teenagers. So when emotions get high and intense, so goes the behavior, so goes the responses, and so goes the thinking processing, as you've heard very eloquently presented today. So we wanted to kind of teach and highlight for these families and the kids how they get non-dialectical, is another way to describe it, in their thinking, or hypermentalizing, one might say, if Carla would say, right, where you're kind of extreme responses to the present moment, and very, very black and white, very dichotomous. You're right, I'm wrong. I'm right, you're wrong. I'm good, I'm bad. I'm silly, no, I'm serious. And how do you find a middle path between this truth and kind of developing a synthesis between what is often polarized stances? For some of the families, they go from excessive leniency and tolerance of some extreme things that are happening, and all of a sudden the pendulum swings once the kid crosses a certain threshold. That's it, you're grounded. You're not seeing any electronics, you're not going out for the next 6 months. How's that working for you? Not so well, right? So you go from excessive leniency to authoritarian control, and the middle path from a parenting perspective is, come on guys, what's the middle path between excessive leniency and authoritarian control? Authoritative parenting. Kind of having some structure, some limits, but having some flexibility, and not kind of going off the deep end on the parenting end either. So there's multiple perspectives. Some of the families we work with pathologize normative behavior and normalize what we think is pathological behavior. And I can validate the families in here who are struggling with that, because your parental compass is kind of on its dial spinning around because you don't know what is normative anymore. I don't know what normative is. So you need some advice and guidance as to what are some typical adolescent behaviors, and those change developmentally from 12 to 14 to 16 to 18. But we want to work with the families, help them find some, from an educational perspective and some emotional perspective, what some balanced ways of approaching some of these situations. So that's one aspect of the teenage and family dilemmas. Another thing that clearly has been highlighted today is this idea of invalidation. And in DBT, we talk about the invalidating environment. And when I first learned about this 20 years ago, and I know Perry and Cindy Sanderson were kind of instrumental in teaching Jill and myself a little bit about DBT at the early stages, we were like, we're going to talk to these families about them being an invalidating environment? I mean, I better start taking cover right now. They're going to feel blamed. And it occurred to us over time that it's just describing problematic behavior, which I engage in, Jill engages in, kids engage in, parents engage in. And you know who else engages in that? Teachers, medical doctors, and a whole host of other people, not just the families. And so once we kind of, took away the blame aspect of it as we interpreted it and just described it as a problematic behavior that many of us engage in if we're not careful, hey, we can just call it what it is and work on better validation. So we're going to teach you validation skills. And thirdly is poor contingency management. Turns out, when you get emotional, and I'm a parent myself, if I get dysregulated, I definitely want to throw down the gauntlet and throw down some major consequences. And as you heard from Francesca earlier, when you hear the jibber-jabbering and it escalating, I can tolerate for a little while, but as soon as I hear my daughter or son screaming at the other one and yelling, then I stop my emailing and I move over and I say, hey, stop that. And I do exactly what Francesca instructs people not to do. Thank you for the early morning lesson. So what we are working on is trying to teach the teens and the parents, in this case, effective parenting management. And you heard it being done with the kids, and of course, with adolescents, it's just as critical. And what we're missing is the positive reinforcement, the natural reinforcements of praise, catch them being good. And when you're depleted and you're exhausted and you're doing all kinds of stuff to kind of just stay afloat as a parent, it is not easy to kind of catch them being good, right? It's hard. So it does require what skill to be able to catch them being good? You have to be mindful. You have to be noticing. You have to be out of your head and be aware of what's happening around you to catch them being good and change that dynamic. We got to talk about extinction. We got to talk about effective punishment, not ineffective punishment, right? So there's all kinds of parenting work we do on kind of contingency management. So that's the walking the middle path skills. Oh my God, this is service with a smile. I ordered this about 2 hours ago, and look at it now. I got Emily, this is delicious coffee. Thank you. Wow, that's great. Okay. Yeah, grind the beans. Yeah, that's good. Yeah, I need that mid-afternoon. You guys know what I'm talking about, that mid-afternoon lull, especially on a Friday. Boy, you need that. Okay. So why DBT for teens? I'm about to share with you some of the data of the randomized trial, but for many years we've had a quasi-experimental and open data, which was promising. The biosocial theory, which many of you know about, if you have questions, I can talk more about it, but it really treats the therapist, treats the family, treats the child in the sense of better having a more empathic, compassionate understanding of how they got to be this way. And when I've presented the biosocial theory to some kids over the years, and teenagers, that is, I see tears rolling down their face because something finally makes sense as to how they got to be here. That I'm wired in a different kind of way in some ways, and as we heard this morning, it's not all bad, right? Having some emotional sensitivity, it can be a wonderful characteristic if you can manage it and doesn't kind of get the best of you. And then the environment that is invalidating, whether it be cyberbullying and peer bullying from your peers and stuff at home and your coaches and your teachers, right? If that's pervasive over time and you're wired to be this way, it makes sense that you have a more emotional dysregulation. So when you can present this and teach this to the child or adolescent or young adult or adult with BPD, there's a whole newfound appreciation and understanding, and it really is validating to learn the theory themselves. Now, DBT is skills-based, and by the way, the biosocial theory, of course, informs the treatment. So if we understand that they're wired to be more emotionally vulnerable, sensitive, and we also understand they're skills deficient, there's a lot of sensitive people out in the world who have some coping skills and don't end up having borderline presentations. But those who have skills, emotional sensitivity, emotional reactivity, slow return to baseline, coupled with significant deficits in emotion regulation skills, that's the recipe, coupled with invalidating environment, that leads to BPD and emotion dysregulation. So we know then we have to teach them emotion regulation skills to deal with that deficit. From an invalidating environment standpoint, it's clear as day to me that we have to teach more about validation. And we had this misconception early on when we started developing this treatment 20 years ago. Oh yeah, we'll just put the parents in skills group, they'll do one rotation, and the kids will have individual therapy, and that'll be that. And then it finally occurred to us, after that not working as well as we had hoped, that we actually have to work with the families in addition to them learning the skills. So it's one thing to learn the skill, acquire the skill. It's another thing to practice in a family session, working together, ironing out all those glitches that inevitably will come up. What I like about DBT for adolescents is it's really skills-based, and they talk about the skills deficits, and kids are used to learning and practicing and rehearsing. And therefore, we're going to do a lot of that with them. And in DBT is this multimodal nature of treatment that affords us various entry points into their lives. I can't tell you what a pleasure it is for me to see some of my individual clients, who also I get to see in our multifamily skills group, and I get to see how they interface with their peers, their families. So I have a whole new appreciation for them in a different social context. So there's a lot of value. And then I speak to them after hours and give them coaching. So there's these different ways of kind of working with them. So I'm going to give you a little bit of an update on where we are in the adolescent DBT randomized trials State of the Union. So a friend, Tina Goldstein, out at the University of Pittsburgh, is underway in a randomized trial looking at DBT versus care as usual, a 6-month trial for bipolar disorder and suicidality, and that's underway. So I don't have any more data to share with you, but she's published some nice open trials and some smaller randomized trials, which are very promising in reducing suicidal behavior and reducing depressive and manic symptomatology and improving family functioning. And she's also demonstrated high feasibility, meaning that the families really find it to be a useful and acceptable and tolerable intervention over those 6 months. And just so you know, with the bipolar adolescents, they do single-family skills training. They don't put them in a group. Marsha Linehan, Liz McCauley, Joan Sarno, and Michelle Burke at University of Washington and Seattle, as well as UCLA, have a large-scale, it's called CARE study. They're nearing the end of their study, and that's a DBT compared to supportive psychotherapy, a manualized treatment. So they have it's manualized control condition, and they're looking at highly suicidal adolescents over that 6-month window. And the first one, number one, is a study that's conducted that we just published this outcome from University of Oslo in Norway. Lars Mellem is a principal investigator, and it's a 16-week DBT versus enhanced usual care. And here's the reference. It was published in the Orange Journal of the American Academy of Child and Adolescent Psychiatry for DBT for recent and repeated self-harming behaviors. And we compared, the control condition was enhanced usual care. And enhanced usual care in Norway, usual care in Norway is CBT or psychodynamic. And what was enhanced about it was that the kids and then therapists in both conditions got training in what's called the U-ramp. Anybody know what the U-ramp is? That's the University of Washington Risk Assessment Management Protocol. And Marsha Linehan and her colleagues in Seattle developed this. It kind of has all the suicide risk factors, and then it tells you at a certain point how to kind of manage it. If you want to get it online, you can go to the University of Washington and download it for free. So basically, they got trained in how to assess and manage high suicide risk. Now, most people in the community are not getting that training as part of their usual care, right? Most of the therapists don't have that training. In addition, the enhanced usual care condition was also notified anytime a patient reported to the research assessors at every 4-8 weeks whether they had any increased risk for suicide. The research assessment team would notify the therapist that their patient was having more suicidality. So there were a lot more protections put into place to make sure, when working with a suicidal population, that we did everything we could to kind of equalize or calibrate at least the risk assessment piece of things. And the treatment was delivered at 5 clinics around Oslo, outpatient clinics in Oslo, Norway. So like I said, it was a randomized trial, blinded, pre-post, follow-up. And we had baseline, 16 weeks, which was really kind of end of treatment. We're coming at the end of the 1-year post-treatment follow-up, which we're going to publish soon, and then the 2-year post-treatment. And only in Oslo, Norway, can you get funding for a 10-year follow-up. You got to have a lot more oil than we do to be able to get funding, federal funding for that. So the patients who received DBT, compared to enhanced usual care, had significantly stronger reductions in the number of self-harm episodes, stronger decline in suicidal ideation, stronger reductions in interviewer-rated depressive symptoms, stronger reductions in hopelessness, and stronger reductions in borderline symptoms. So again, this is a 16-week outcome, and we felt that that was, I mean, with the sample, did I say about 77 subjects split between the two conditions. So it didn't have a huge sample size, but good enough to find some nice effect sizes and significant outcomes. So, all right, if there's questions about this, I mean, I'm sure there will. I'll answer those in a little while. All right, I already talked about the biosocial theory. I don't need to go over this. Unless there's questions, I'm going to skip it because many people have heard extensive conversations about biosocial. So I'm going to power through these slides. Suffice it to say, though, that I was just spent the last 2 days working with teachers, educators in local public schools, and I spent a lot of time with them teaching them the biosocial theory because some of these very well-meaning teachers have this idea of, validation means encouragement and praise, and they don't fully appreciate the function of validation. And so we did a lot of role-playing with them, and we kind of introduced the whole biosocial theory. So they had, I think, engendering a lot more compassion for some of their emotionally dysregulated students that otherwise they feel personally don't like them, and they over-personalize the students' behavior as an attack on them as teachers. And so we did some good work, and they really want to have their other teachers who were not present for the training to learn about this too, because there's just not a lot of education for teachers about understanding these mental health types of issues and sensitive, emotionally reactive kids and what to do. So validation in and of itself, we know can help, if it's done well, can reduce emotional dysregulation in some of the kids we're working with. So many of you here know about the structure of DBT with adolescents, but wanted just to highlight that when we introduce DBT to families and teenagers, we talk about these assumptions that we think are useful if DBT is going to make some gains in DBT. So the first one, I typically ask the most disgruntled parent in the multifamily group, do you think, can you read number 1, Mr. Smith? And he says, well, people are doing the best they can. And now realize this is 4 or 5 teenagers and their parent or parents sitting around a large conference table. And I specifically selected, I thought, the parent who was having the most difficulty. And usually that parent's about to embark on a diatribe about how that's the most ridiculous statement they've ever seen. Because how could Jessica be doing the best she can? She's here. She's been hospitalized. We're thinking about sending her to wilderness treatment. It's impossible. She's doing the best she can. So I say, Mr. Smith, when Jessica was dreaming up her adolescence a few years ago, do you think she was imagining being here with you and me on a Wednesday night in a multifamily skills group talking about this stuff and having to deal with a lot of the stuff she's dealing with at school and home? This was not her plan. If she could effectively manage some of her emotions and impulses differently, don't you think she would be? And he's like, I guess so. I guess. So by definition, then, I think she must be doing the best she can in this moment. Will you give me that much? Okay. Now, what about number 2? People need to do better, try harder, be more motivated to change. Yes, Mr. Smith's back on board. That one's definitely true. So I want to introduce this core dialectic of DBT. Mr. Smith, Jessica, in this moment, I have to believe is doing the best she can, because if she would do better, she would. And by the way, Mr. Smith, you, as the dad, I have no doubt you're doing the best you can with your daughter, and I have to believe there's some areas that you yourself might be able to improve in to be more effective parent. Is that possibly true, Mr. Smith? Just go with me on that. Is that true? Okay. And by the way, your friendly neighborhood skills trainer, I'm doing the best I can in this moment, but I have no doubt I skipped over some biosocial slides that I feel badly about now, and I know I want to hit some of that more next time. So I think universally speaking, we're all doing the best we can in this moment, on the one hand, and we need to do better, be more effective, and try harder. And I think that's the core dialectic of DBT. And if you can hold these two truths that seem like opposites at the same time, you're now understanding this first construct of dialectics. I go through some of these other assumptions that people want to improve, that teens and families must learn and practice new behaviors in all the different situations in their lives. So this gets back to this skills deficit notion, which I think, there's definitely a lot of similarities between mentalization and DBT, and there's some differences, and one of them is this notion of a skills deficit that requires learning new skills and practicing and setting them out and giving them coaching. And I tell them when I teach in the skills group, we can all have a good time here on Wednesday nights and laugh and so on and learn some new stuff, but unless you practice this stuff with meaning and find that this is a necessary thing for you to build a life worth living, I'm afraid this may be, could be a waste of time, and I don't want to do that. People may not have caused all of their own problems, but they have to solve them anyway. So this, again, shit does happen. There's no doubt about it in our lives. And, whether it be divorces or deaths or moves or having a chronic medical illness that you can't, or a chronic mental health condition, there's all kinds of things that happen that you cannot necessarily change. And yet, this is the cards you were dealt, and how are you going to deal with it? Things happen, and you have to learn the skills to cope with it. And of course, the lives of emotionally distressed teens and families are painful as they are currently being lived. Now, when we talk about individual therapy in DBT, we think of as stages of treatment approach, and one of the things that I think beginning DBT therapists kind of rush to do is rush to work on, severe behavioral problems. And the clients themselves, whether it be teens or adults, say, hey, let's go. I got a lot of stuff going on here, some of them. I need help. And sometimes, though, we skip over what I think is a critical point, which is the pre-treatment stage of treatment. And in that stage, I want to kind of assess, I want to build rapport, I want to have trust, I want to kind of gauge where they're at and understand that they have agreement on some goals before I move the train out of the station and work on some of the more significant life problems that they're coming and presenting with. So I just want to remind those of the clinicians in the room that just because they show up to your office, that they're depressed, suicidal, borderline spectrum, disordered eating, and substance abuse problems, that's a lot going on, yes. And unless they've agreed to work on some of these things, I wouldn't start moving them into skills group and working on treatment, if you will, until they've had some agreement. Now, of course, pre-treatment is treatment, right? Getting commitment, motivation, agreement on goals. But I think I see where a lot of times DBT fails is they're rushing them into skills group because they're here and they have a lot going on, and I'm anxious as a therapist, so let's just put them in the treatment program. And that's a mistake that I want you to be careful about. The other thing, just to remind folks, is that I think we sometimes, if people have trauma histories and they want to have treatment for their trauma, but they're still self-injuring, they're still binging and purging, they're still abusing drugs. From a stage theory, that would fall under stage 2 or level 2, right, in terms of helping process past emotional trauma. And there's a time and a place for that, but it's not until they have acquired some skills and some capacity for emotion regulation in some distress before we kind of usher them into trauma-focused treatment, okay? So this is a kind of a, DBT is a principle-based treatment, and it has certain structure to the targets, and if you visualize a treatment target hierarchy, we're obviously trying to decrease life-threatening behavior first and foremost, therapy-interfering behavior. Now, who engages in therapy-interfering behavior? The client, or the teenager in this case, could come late, not do their diary card, not call me for coaching when they need to. The family could engage in therapy-interfering behavior. They may be saying, okay, Johnny, this is your treatment, this is your show, we'll drop you off if you're lucky, but You know, sometimes the family does come in full throttle, let's do this, and they're kind of so excited sometimes that it's also therapy interfering, because anything that good from a parental perspective has to be terrible from a teenager perspective. So I tell the parents, tone it down a little bit. Don't talk it up so much, because they're going to scare them off. So there is a little bit of that. But then sometimes the families could be not necessarily as eager. I've seen in a lot of the families in the Bronx, they have so much to manage on their plate. They're single parents, you know, poverty. They have trouble getting in at all, some of those cases. Okay? And then in other cases, I've heard from kids that the parents say, don't tell them all about this personal stuff, and there's some therapy interfering behavior on behalf of the parents, or they're not doing their homework. They come to group, but they don't do their homework, but expect Johnny to do their homework. So I'm giving you extreme versions. Many of the parents I work with are absolutely fabulous, highly motivated, and wonderful, but I want parents and families to be aware of that they may engage in, at times, some therapy interfering behavior. And of course, the therapists, ourselves, can be known to engage in therapy interfering behaviors. What are those? Coming late to session, not returning phone calls in a timely fashion, being a little too change-oriented or too acceptance-oriented and imbalanced from a DBT perspective therapeutically. So there's a lot of things that we're keeping an eye on, and I want my kids to know that I could equally engage in TIB as you, and if it happens, we have to address it. And only after that will we then get into quality of life interfering behaviors, which is what most people think therapy is about: the depression, relationship challenges, substance use, and so forth. And while I'm trying to decrease targets 1, 2, and 3, we're trying to increase all the behavioral skills that they're going to learn in skills group. All right, now, so that was just me trying to orient him, and we can certainly talk more about. I wanted to just take a clip that highlighted how I described, in like I said, in very compressed fashion, the modes of the treatment to him. What I cut off is a little bit of the fact that I have a therapist consultation meeting where I meet with the skills trainers and we talk about how to best help him and his family. And I also told him about some family sessions as needed. Just so you know, though, in adolescent DBT, after 5 or 6 months of treatment, and now the randomized trials are 4 months, but some of the work that Jill and I put together now have skills that kind of fill a 6-month curriculum. That model is yet to be researched yet, so we have to see at the 6-month level if it's more or less effective. But we have a graduate group, and my feeling is if you're going to work with kids who have a multitude of issues, it's great to get some kind of remission of these symptoms, if you will, or behaviors or problems. But undoubtedly, after only 4 or 5 or 6 months, if they've been dealing with these things for quite a while, there's going to be a chance of high degree of relapse if you don't have some kind of maintenance or continuation phase of treatment. So that brings us to the graduate group, which is the highlight of my week clinically, when I get to see teenagers who have been working on kind of acquiring the skills in the multifamily group and now putting them into practice where they consult to their peers about problems they're having during the week, and they have the interpersonal validation and support and feedback about how to be more effective in reaching their long-term goals. So that's going on as well. This is a shameless plug for the manual that Jill and I just came out with, but I'm referring to the skills, so I felt like it was a reasonable excuse to at least show you the picture before I talk about some of the skills that are in the book. And this is the kind of curriculum, like I'm alluding to, that is about 24 weeks long. So we have 2 weeks of orientation and mindfulness, and then 4 weeks of distress tolerance. 2 weeks of orientation and mindfulness, where new people can enter the group, 4 weeks of walking middle path, and so on. Okay? Now, I already talked about some of the middle path additions or skills, and so I don't need to spend too much time on it. These are some of the dilemmas that we've identified that I've alluded to in terms of teens and families getting polarized and teaching them how to find more of a middle path. And in terms of middle path, in addition to teaching them dialectical dilemmas and dialectical thinking and acting, we also talk about teaching principles of behaviorism and learning that I mentioned earlier. And Jill Rathis' graduate student, Bevan Campbell, led a study, or actually a dissertation, on the acceptability of the walking the middle path skills, right? So dialectics, behaviorism, and validation. And we took 50 parents and teens taken from our Bronx clinic and Montefiore, as well as Jill Rathis' group practice, and used a mixed methods approach. And the results were that that these families found these skills highly acceptable to both teens and parents. And of all the 27 skills that we do teach, they found the middle path skills to be ranked most highly and most helpful, and the skill of validation itself was considered most beneficial skill among all our 27 skills, with reinforcement close behind. And if you don't believe me, ask Oprah Winfrey on her 25th anniversary year show. She said of all the skills that she's learned, not DBT that is, but of life skills, validation was the most compelling and important in her mind as well. So you don't have to believe me. Oprah really, right place? Is this true? Yeah. So I thought she said that. Some of the additional skills, though, that we've added to the manual, you know, when you're working with kids whose emotion dysregulation is so intense and they're just they're kind of out in the ocean and they're floating around and their head is bobbing and they're just trying to get air and stay alive, if you will, it's very hard for them to kind of be goal-oriented. They're in crisis survival mode, right? They're just barely staying afloat. So it's hard for them to be clear on a week-to-week basis, what am I working toward? And so one of the things that I think was missing that we eventually added to this manual was helping these kids gradually, as the dysregulation comes down, have a greater awareness of their wise mind, goals and values and priorities. You know, is my value or goal to be a leader? Is it to be healthy? Is it to be part of a group? And kind of having them find their wise mind around that to then inform what are some of the goals and things we're going to be working toward in treatment. Another thing that we realized working with families is that we had all these pleasant activities for kids to work on separately. Parents, you go have fun by yourself. And we realized that part of the problem is that there's a gradual kind of divide, and they're kind of engaging in separate tracks. And we wanted to kind of prescribe some teen and parent shared pleasant activities, both for each of their own emotion regulation strategies, under which that's the module, but also for obviously enhanced positive family interactions. So that is a big part of the emotion regulation piece with the teens and families, and prescribing fun, prescribing pleasure. You know, they're like, I don't have time for that. I understand, but you made in your appointment calendar time for this group. How do you do that? Well, you put it in your calendar as Alec Miller Group. Good. Okay, now I want you to find time and put into your calendar, and that's your pleasurable activity time, either alone or with Johnny, but you have to schedule it. It will never, ever happen, ever, unless you build that in. So we got to schedule that. A lot of the kids are depressed and hedonic, and they are not going to do this without some major behavioral activation and scheduling. Turns out that many of the kids we see also have major sleep impairment, and it's not a coincidence that the sleep, impaired sleep coincides with mood episodes and increases in self-injury and suicidal behavior. And so we've been targeting that. You know, it used to feel like such a lower target. Oh, just a little sleep problem. You know, we have so many bigger fish to fry. But if we can deal with this as a major vulnerability factor towards more depression, more self-injury, more suicide, so now it's on our diary card, and we're giving them prescription for 12 steps of better sleep, good sleep hygiene, and everyone in this room knows how much your food affects your mood. And so we're doing a lot on nutrition and healthy eating and balanced eating. So I'm aware of my time. I'm trying to figure out the things I want to highlight in the remaining time I have. You know, I've alluded to this, but the importance of involving families, not only in the skills training group, but also in teaching family skills. And a lot of the parents we work with have some very good skills, but when they themselves get dysregulated, it's very hard to apply those skills to that child or adolescent in the moment. So we're going to review those skills, strengthen those skills, and then bring them into family sessions where we're going to do some in vivo coaching. And sometimes we'll do a family chain analysis where we might have a teenager who's engaging in some kind of problematic behavior, and I'll do the adolescent behavioral chain, and then alone. Then I bring mom or dad in and say, I understand you were involved in the situation with Johnny, that we have to figure out what happens so we can kind of avert this problem next time. So let's get your chain. And so Johnny listens as mom or dad presents their chain, and we kind of see where some of the problematic links in this family chain are, and come up with some solution analyses for both parties so they can avert that outcome and have a better trajectory in their next interaction. So it takes some slow, tedious, sometimes painful, sometimes intense emotional discussion as we tease this out and then prescribe collaboratively some solutions to avert that problem for next time. So I want to spend a few minutes talking about DBT in non-mental health settings, schools, and those for medically non-adherent youth. And I think that most of the folks in this audience, we've been doing DBT downstream for a long time. So, outpatient DBT, IOP, residential, inpatient, that's all good. But what about this notion of starting DBT further upstream? So, about 10 years ago or so, myself and some colleagues started doing some school-based DBT. A health teacher up in Ulster County asked me whether I could give her some curriculum and she could do it in her health class because these kids in Ulster County had major substance problems and depression, and she knew she was not a clinician, she was a health teacher, but just had a sense that they needed some tools. And she was teaching all this curriculum for health, but realizing that it was kind of very disparate, and she thought if she could give them some life skills in health class that was underlying some of the other curriculum, maybe, just maybe, that would have some, an effect. We didn't get any IRB approvals. There was no research formally conducted in that setting, but that's where my mind started going in terms of doing some school-based DBT. Then some other psychologists in the Westchester County community where I live said, what about we have these kids that are really kind of what we call frequent flyers in the schools that end up in the principal's office getting sent out of district, and we don't know what to do. Can you teach us DBT in a more comprehensive way, what you do on your outpatient setting? Can we do that in schools? I'm like, I don't know, but let's see if we can try. And so we started doing that. And so there's kind of a two-pronged approach. One is the kind of more targeted, what I call secondary and tertiary prevention interventions for elementary, middle school, and high school. And those are for the kids who have multiple problems, who are already showing up in front of administration, CSE meetings. They're not all classified. And then there's others who are thinking about DBT on a more universal, class-wide primary prevention model. And for the comprehensive DBT, we've been using the manual Jill and I did, and more the formal DBT. There's a program called STEPS, DBT STEPS A. Jim Mazza, Liz Mazza, Jill Rathis, and I, Elizabeth Murphy, have a book called DBT Skills Training for Emotional Problem Solving for Adolescents. And this I will tell you about. So I just want to give you what I think is an interesting conceptual point, which is in schools, you know the expression WTF? It's called waiting to fail, waiting to fail. So waiting to fail is that these kids do not get help until they're really struggling, right? So there's not a lot of prevention in schools. And so once they have problems, then they get classified, and then they get these resources. And so what we're trying to figure out is there a way to kind of embed some of these life skills in schools to help with late elementary, middle school, kind of learning how to be mindful, learning how to tolerate distress, learning how to regulate emotions, learning how to be interpersonally effective when, pre-puberty, puberty, and then before their mid to late adolescence when they end up at Tier 4, adolescent outpatient services, residential treatment, and hospitalization. So can we get it in earlier? And so Jim Mazza said, what about a universal population? Can we just get it into classroom settings? And so that's where the STEPS A model is kind of coming in. I know there's some folks here in the Stanford School District. I don't know where Jen Jenkins is. Is she in here? Yeah, there they are. So you guys are there. So they're going to be doing it in local high school in Connecticut, and the kids are going to get credit, right, for participating in learning these life skills in high school, which is wonderful. So there's kind of different models where we're going to do that. And then there's the more school-based mental health approach for those who need more than just from a prevention standpoint, but they need individual counseling, they need coaching during the day, so the mental health team and the school guidance counselor and the special educators are meeting on a weekly team meeting. So they have team meetings in school, they have all the modes and functions of standard DBT in a school setting. They're getting coaching, they have team meetings, they have skills training, they have individual counseling. So that's going on. And that's happening, here's a list of some of the local school districts here and on the West Coast a little bit where they're doing either comprehensive or Steps A. Francesca did this actually in New Haven. We published a paper about 5 years ago in a local school of the Yale's kids, right? Was it the Yale's kids? And so they were a very special, unique group. The Yale professors. Private school. Oh, not a Yale school, private school. But they were very a specific group. Erica Lander and some of my friends from the Bronx did something at PS8 Elementary School at Montefiore. So we've done it in different kinds of settings, elementary, middle, and high school. Why the administrators in the school districts are kind of saying, hey, this seems useful. What do the administrators in schools care about? Dollars. And they find that they send a kid out of Westchester High School into a specialized educational setting. It's about $100,000 for the treatment, education, and busing. So they say, well, maybe we'll spend a few bucks having you train our staff then. And that's seriously how the administration thinks. Now, in addition, we have some interesting help in terms of pointing out that we can reduce their ER visits, psychiatric and medical hospitalizations. 20 years I've been spending in the Bronx and Montefiore. We have the second busiest ER in the country. And the ER is overloaded with whom? Kids from the local schools. And why? Because they somehow either wrote something that expressed some suicidal thinking, have a superficial cut, something where the school's mandate is you do not pest go, you do not collect 100, 200, you go to the emergency room if anything sounds self-harming. So these kids now are removed from the school, have to be disrobed, put into a gown, monitored by security, have to be then evaluated in the middle of the night, family has to leave work, then they have to be ushered to some psychiatric hospital. It is a very dysfunctional system that we need to do better and being able to help these schools do a better job assessing risk, managing this in the school system. And so we're working on that with the local schools I'm talking about. Now, I know I can tell Seth is getting antsy and he's going to be coming up here momentarily. Some data from the schools. So preliminary, very, very preliminary, rough data from this local high school in Ardsley. They found that just doing this after 6 months, those kids who they were treating with comprehensive DBT had reduced referrals to the assistant principals, reductions in cutting class, reductions in detentions and suspensions, again, compared to the prior 6 months, and then anecdotal reductions in depression, anxiety, and NSSI. The challenge is the school culture is like an emergency room. They will respond to crises, but lower-level problems they don't attend to. So from a behavioral perspective, it is pretty much a disaster. So we have to get buy-in from upper administration to not over-respond and overreact to every problematic behavior and not wait till it's code red. And so I've had a patient in my practice who I was working with who was also seen as the school social worker at the local high school, and she was really out of control, seen daily. But then as she was getting better, the school social worker saw her weekly. And then even in the weekly sessions that sometimes get interrupted because the principal would bring another student in who was more highly dysregulated, and my patient got kicked out of the school social worker's office. And she's like, it's almost like I have to raise the ante to get some attention around here. I said, it does feel that way. We got to work on that. We can't have the school systems operating in this way. So, all right. Steps A, I'll just tell you real quick. Sorry, the structure for Steps A is that there are 30 lessons, there are 50-minute periods. You can kind of go, teacher curriculum. Step 1, open your binder. Step 2, take out your pencil. Step 3, read this, and we're going to teach you in a much more didactic teacher, general ed teacher kind of way. And that covers all of the domains of standard DBT and use a lot of the skills handouts that Jill and I developed. And so there's a teacher manual and a student workbook, and there's more we can talk about. The Dalai Lama, of course, says that when you're educating the minds of our youth, we must not forget to educate their hearts. The last thing I want to say about other adaptations of DBT, which some of you might find interesting, is that a former intern of mine, Becky Hashem, now Becky Lois, realized that working in the Children's Hospital at Montefiore, there were so many kids with chronic medical illnesses that were non-adherent. And what DBT is uniquely good at is getting non-adherent individuals to be more adherent with X, Y, and Z behaviors. So we decided to develop a 6 or 7 session adaptation of DBT for kids with chronic medical illness. Started with kids with chronic kidney disease who were essentially blacklisted from transplant because they were so non-adherent that doctors were like, we're not treating that kid. So we gave these kids this intervention, and 6 out of the 7 kids who got this brief intervention got back on transplant list and transplanted, which was very lovely. So we said, what about adapting it for diabetic youth? That's a big problem. So now we have some funding to do that study, and we're underway looking at that. So in sum, I think what we need to do is publish the results from all the existing randomized trials with adolescents, including the large one from UCLA and University of Washington. You know, I was talking earlier with Carla about, you know, I had the privilege of getting trained by Anthony Bateman and Peter Fonagy recently in mentalization-based therapy. Jill and I had a good time going up there together and learning from the experts. And there's undoubtedly, you know, they have a lot of overlap and there's differences, and I think for some kids they don't respond as well to DBT. You might add some mentalization. Maybe with some kids don't respond as well to mentalization, you add some DBT. And what are the unique factors, common factors, different factors, and can they complement each other? There's research there. It's got to, that'll be in the next step, because we already have an MBT randomized trial that shows that it's very promising with some of our kids. Is DBT skills training alone effective? Can you just do skills training without individual? It has to be done. Is DBT effective for children younger than 13? Francesca is answering those questions. And then looking at this in a much more rigorous research way in schools. I'm very passionate about the school piece. You know, for years it felt like with adolescents it makes sense. You know, anecdotally we think we know it works, but now we need data, and we got data. Same thing with schools. It feels like it makes sense. Teachers are hungry for it. Psychologists in the schools are hungry for it. General ed teachers, some of them are even getting hungry for it. We got to research that. And then obviously for chronic medical illnesses, we have to see if that's working, and we have some data on that. But finally, can we help prevent borderline personality disorder through some universal skills classes? Can there be ways of teaching these life skills at younger ages, 4th grade, 5th grade, 6th grade, and acquiring and practicing these skills? Just like they learn English, math, social studies, why not, can they not learn life skills? Anyone? Please. Thank you.
Thank you so much. Thank you so much, Alec. Thank you so much, Alec. Am I on? Is this on?
Yeah.
You are? Okay. We have a couple of questions relating to some of the dialectics you referred to. A few came in asking for help distinguishing between BPD features and normative adolescent acting out or fun or some of the things that are typical of adolescents from what's BPD features.
So what's normal adolescent behavior, meaning, you know, some
problems of identity. People mention problems of identity, chaotic relationships, affective lability. Yeah. That's adolescence.
It's a very tough. You all heard the question. I mean, my working kind of way of thinking about it is, if you can have all kinds of pretty egregious things happen in adolescence, but only when it becomes impairment in functioning do I say that it would warrant more of a diagnostic application of BPD or whatever other diagnosis it is. So adolescence is a time of experimenting, doing some very unthoughtful, non-mindful things, and risky things, I would say. But if it starts to impair functioning, I would say that's when you have to think about more of a diagnostic picture.
Oh, and also, different dialectic, would you explain the dialectic of forcing autonomy and fostering dependence?
Yeah.
What does that mean?
So fostering dependence versus forcing autonomy. Fostering dependence, sometimes you'll see where a kid has a problem in a classroom. Let's say, you know, a middle schooler has a problem with a peer or a teacher. Fostering dependence would be the parent swoops in, tells the administration of the school, I want my child removed. I don't like the way this teacher or student's dealing with my child. I want that problem fixed. The child does nothing to solve that problem, is just kind of at the whim of the helicopter. Follow? So that's fostering dependence. Forcing autonomy, though, is when you have a problem and you have an adolescent who's struggling with something, and the parents sometimes say, this is you, baby, you're on your own, this is either your therapy, this is your problem to solve, oh, you got yourself pregnant, okay, well, it's time to maybe find your own place. and it's kind of moving them prematurely into their adulthood or more responsibility than they're ready to handle without adequate coaching and supervision and parenting. Those are the extreme poles. Obviously, we want to move them to the middle.
We have a couple of questions about engaging individuals. There's one about what do you do if the person is resistant, if the adolescent is resistant? At what point would you terminate with a client who's refusing the gold standard treatment for his disorder? There's another one about the individual becoming passive, maintaining a role of passivity, going into hospitalization. Again, so there's two about engaging.
So in terms of passivity, in terms of preferring a hospital, I mean, one of the challenges I think we have as a healthcare system and as families and caretakers and therapists is how to make their, wow, I'm getting very loud here, how to make their outpatient life at home and at school and in treatment more reinforcing, if you will, than inpatient. And, you know, I've consulted to Bronx Psychiatric Center where it's a state hospital, and the staff looks at me like they're amazed at why they wouldn't, if someone's been there for 10 years, why wouldn't they want to get out of a state facility and go back to the community? Well, some of these adults in the state facility have established families with their staff, their peers, 3 square meals a day, and if they go out there, they don't get all that. So we have to think creatively about how to make their outpatient experience better than their inpatient, and we have to make their inpatient experiences a little less good. I got to say, I've been consulting to some places, I've worked in some places where, you know, they go into seclusion in the quiet room, you know, these teenagers are there, and then they have these 20-year-old attractive men and women fanning the magazine section. Which magazine would you like? And what food would you like right now? And you know, so it's like, you know, you want a mani and a pedi while we're at it. So that's almost too good, and we have to dial that back.
And anything else to add on the person who's refusing to do the gold standard, and is there a point when you would terminate because they're refusing?
You know, there's some kids we've seen who've been in pre-treatment for a lot longer. They're just not, you know, and it's, I don't know who they are at the outset. Sometimes I think people who be highly committed turn out not to be, and those who seem apparently unenthused get engaged quickly. So, I mean, we could probably there's a little research to be done in that arena. But I'm an optimist, and the glass is always half full for me, so I'm rarely thrown in the towel prematurely. But at a certain point, if in discussion with the family and the teenager and my treatment team, we deem it, you know, this is not effective, or the behaviors are getting worse and dangerous, well, then we have to think of alternative levels of care. But they often get to us, it's kind of the last stop before they send them out.
Are there DBT components that are not a good fit for adolescents given their stage of development?
Are there DBT components that are not good for their stage of development? Not that I think the group is a natural for them, right, with their peers. I think what's not less natural is peers and parents, and they don't necessarily get excited about that at first blush. And they say, don't make me do it, don't make me do it. And so that's a common response when we introduce the multi-family format. So that's not as natural for them to talk about whatever issues they have in front of their parents in a multiple family format. But so I think it's a little awkward, but I think it's effective in helping them see that their parents are also struggling with some issues, that there's other kids, and there's a universality to it, that the kids can learn from other kids, the parents can get support from other parents. So I still like the modality, even though that's not as naturally inclined for them, probably.
This person points out that hormones, estrogen, testosterone changes strongly affect emotions. Do you see a role for education regarding biology for teens and adults in family DBT?
I mean, I think there's definitely room for that, and I think certainly in individual sessions we talk about some of that personally and privately with some of the kids. I think it could be added to the curriculum as normal kind of development. They should get that in their health curriculum if they're going to it. So I'm not against it. I don't know how much we need to amplify it.
This person speaks to the texting as the primary form of teen communication, and what advice you might have for BPD teens for how to adjust their use of texting to be more mindful, less impulsive, anything like that.
If you can't beat them, you join them. For many years, I was like, I'm not texting. I am not texting my kids. I am not my patients. I'm not doing it. It turns out that they have voicemail phobia, they have regular phone phobias, they have such familiarity and comfort with this that I myself will text them for non-life-threatening coaching situations. And at the same time, I want them to practice being unplugged during my sessions, during groups, and hopefully at other designated times where they can practice living life more mindfully without multitasking between their texting and their talking and their, I mean, you go to a urinal and you pull up next to somebody and they're texting and wherever you go. It's universal. It's a problem across society. So I don't blame the kids or the parents in the room. We're all modeling that for our kids. So it's not like a kid problem. Let's be clear, guys. The adults, we're guilty too.
Do teachers and students attend the school trainings together like parents and the teens in the outpatient?
Say that one more time.
Do teachers and students ever attend the school trainings together similarly to the parents and teens in the outpatient?
So yeah, I mean, some of the teachers, the students in the schools have teachers in the room, whether it's the school psychologist doing it with one of the teachers, so they'll get exposure to the teachers and the kids getting it together, yeah.
And actually, I'm going to go back to that one. Do the teachers also, are they pushed to learn the skills in front of the adolescents, use their skills in front of any of that sort of thing?
No, we haven't gotten to that stage, although that's an interesting thought. It's an interesting thought. We have not gotten the teachers doing their homework per se like that and sharing it, but that's an interesting idea. Yeah.
How do you involve the parents when doing DBT in the schools? Do kids continue regular outpatient treatment?
So some of the kids in DBT in schools have individual and group at school. There's also these team meetings at school, and then the parents will get invited in, like in Ardsley High School, for example, they'll come in once a month for like an hour, 90-minute kind of skill review so they can get to hear what the kids are being taught weekly. So they come in that way. At PS8 Elementary School in the Bronx, we'd have the kids, 4th and 5th grade kids in a skills group, and then the parents would come in, late after, or mid-afternoon or late afternoon for a parent skills adapted version for them. There's different formats, but we do like to get the parents into the schools whenever humanly possible. It's more challenging, of course, a lot of obstacles to that.
All right, thank you. And the final questions I have, thank you, Dr. Miller, Alec. The final questions I have, I've got some broad questions about DBT that I could put to the panel. I'd like to do that transition to this last part of our program day, invite our speakers up to the stage to have a seat at the table. There are microphones set up. Alec, if you'd have a seat.
Thank you.
Thank you very much.